If you're a DPC physician looking to refine your sales pitch, overcome objections, and confidently communicate your value, you won't want to miss our live virtual workshop on February 11th. Join Lauren Tancredi, a cash pay medicine expert with nearly 20 years of experience, as she shares proven strategies to help you sell your practice with confidence. Whether you're struggling with patient objections or just want to fine-tune your approach, this interactive session is designed just for you. Reserve your spot now at mydpcstory.com. Just head on over to the events page for all the details. And for more insights, go to the top of your feed right now to listen to our latest episode where we talk about quote unquote selling your practice in a culture where we still hear most patients say, "But I have good insurance." Now, let's dive into the episode. Thinking about bringing on another DPC doc? Well, Dr. Phil Hellman of Paradox Health has done it, and he's sharing his experience in this episode replay. Tune in to hear his insights on building a strong DPC team and how he provides innovative, cost-effective care. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
For me, DPC is the architecture that enables me to practice medicine how I've always wanted to. Hi, I'm Dr. Phil Hellman with Paradox Health, and this is my DPC story.
Dr. Phil Hellman is a family medicine physician in Rochester Hills, Michigan. He had no family in medicine, but for him, the path to becoming a physician made the most sense. He went on to Grand Valley State for his bachelor's and then followed with the MSU College of Human Medicine to attain his MD. He did his residency in Greeley, Colorado at North Colorado Family Medicine. His training there was excellent and is owed in large part to an exceptional group of mentors and faculty on staff there. With his wife, Dr. Hellman relocated to Silverton, Oregon for his first job out of residency in the summer of 2016. Although they cherished their time there, they made the tough decision a year later to move back to their family in Michigan, where they felt they were being called. That year and a half of work in the healthcare industrial complex opened his eyes even further to the deficiencies of modern healthcare. Its clunky, bloated, and misincentivized structure was not something that excited him. He always felt terrible when a patient would get a large medical bill, despite paying large insurance premiums, or was told the most effective therapy for their malady was not an option. In March of 2018, he decided to form Paradox Health and started taking part in the DPC model of healthcare. It is something he thought about since first year of medical school, and ultimately, what he had always wanted to do. It just took the right prodding and the right people to tell him he wasn't crazy. He currently resides in Rochester with his wife Chelsea and their 4 children, Merritt, Luella, Hattie, and Hannon. Welcome to the podcast, Dr. Hellman.
Hey, nice to see you, Marielle.
So I will say, back at the level 3 track of the DPC Summit this summer, Dr. Hellman was doing a presentation on lipidology. And I went up to him afterwards and I was like, "Are you a cardiologist doing direct care?" He's like, "No, I'm a family practice doc." And I was like, oh my gosh. So this is an example of how,
That's because I failed to introduce myself to the whole group.
That is one way to think about it. The way that I think about it is that you have the time because you have an interest and you have a desire to know more on, in this case, lipidology, and you have the time to do whatever research you need to do to be able then to take that research to fellow physicians as well as your patients and give them the most up-to-date information. And it sure as heck has affected my practice. So you having the time to do that is woven into your story, which we will obviously get to. But, I just wanted to mention that because it is so important that as people listen to these podcasts, you hear how time manifests in people's lives. But I just wanted to really
shout out there that I'm grateful that the time you have had has allowed a talk on lipidology, and you're, delving into that. So with that, let's get started by, I was really inspired on your website when you said that you didn't come from a family where everybody was doctors, but you really got inspired to, get involved with knowing more about the human body and about medicine when you were in high school. So let's start off with telling us more about what happened in high school that started your journey in medicine.
Yeah. So I think like most high schoolers, I didn't know what I wanted to do. So I sort of worked backwards and I kind of knew what I didn't want to do. And then if along the way, I had a few positive experiences that kind of pointed me in the right direction. So I was, in general, the whole idea of business, I had no idea what that meant. And I had kind of a negative connotation with it. And so I thought, well, I'm not doing that. And now I own my own practice. and I took high school anatomy, and it just came easy to me. So I thought, okay, maybe something in healthcare, biology, that kind of thing. And then I also went on a couple of mission trips in high school, and I really enjoyed those experiences because a lot of them involved just directly helping people. So just that kind of hands-on, being able to have relationships with people and help them in a more direct way, rather than in a lot of places where you're kind of helping people indirectly, which I now appreciate, but didn't at the time. I kind of thought I'd really like to do something where I'm kind of more hands-on, directly helping people. And so that kind of led me down the healthcare path.
That's awesome. And I will put out there, I was just talking to my cousin Jackson, he's in college, but he was talking to me about how he had this non-healthcare related experience in doing research in Hawaii this summer. And he's like, well, I know I want to go into healthcare, but it's not really healthcare related. And I'm like, do not sell yourself short, because every single experience we have, like for you, it's like at the time you thought you didn't like business. That's awesome that you are a thriving business owner now. But, you had these experiences with what is directly helping someone versus indirectly. And it does not have to be in medicine, but don't sell yourself short in terms of all experiences that we have going into becoming doctors, going into becoming DPC physicians. It really matters. And for you then jumped into, like, once you graduated from medical school, you went to Greeley. And my husband and I had looked at the Greeley program, Greeley, Colorado, because it was one of the, we looked at full scope family medicine, unopposed programs. And Greeley, exemplifies what does it mean to have a full scope family medicine training. So tell us about your experience in Greeley, and tell us about especially the people that you studied under, the people who trained you to be thinking and learning like Dr. Hellman does today.
Yeah, Greeley was phenomenal. I mean, I could tell jokes about it because I had applied to some other programs in that same state and had a friend who lived in Golden. My buddy who lived in Golden, I had interviewed in Greeley, and I had interviewed at some programs in Denver. And he was like, shoot, man, you better interview well in Denver because you don't want to go to Greeley. And so it's kind of known as like the town in Colorado that's like the ugly stepchild. But it's also one of those towns where when you go there, at first you're like, I can't wait to move. But then after you're there for a couple of years, you really fall in love with it. And you're like, this is actually a great place. So like you said, the training there is definitely full scope. It's about a 350 bed hospital, North Colorado Medical Center. The only other program there is podiatry. And if you want to, you can train in surgical OB, and you can also get training in scopes. So EGDs and colonoscopies. And I did both of those things, and in large part, I think a residency program is all about the experience, right? And the experience is provided by the type of hospital you're at, the location you're at, which kind of determines the patients that you see and then the diseases that you see. And then it's also about the people that are training you, right? Because they're really responsible for your education and keeping you in line and making sure that you're prepared when you leave. And so we just had some excellent faculty that, themselves were full scope docs. And, one in particular had practiced, independently in Kansas for like 20 years. And he just had all these crazy stories. He had delivered like 5,000 babies. And he was actually, out of him and all the OBs that had privileges at the hospital, he was the only one privileged to use forceps because nobody else basically had used them.
Yeah.
And he was just happened to grow up in the time when that was sort of trained. And so, we actually used forceps a handful of times during my residency program, which I think even most OBs never touched them. So it was really great. And then I continued doing that when I left residency. I kind of kept up all those skills.
That's awesome. So when you were then going from residency into finishing residency, looking for what do I do next? Mm-hmm. Did you always seek to find an employed position, or did you seek to do an independent practice, given that your initial high school self was like, I'm not a business person?
Yeah, I didn't really have a preference. It was really just about the total. Like my first two boxes were really location and privileges, right? So for all the residents and med students listening, obviously getting privileges for a family doc can often be harder than if you're a specialist. And so especially for OB and for scopes, you generally have to be in a more rural area if you want to be doing C-sections and scopes. And so, you're kind of limited as to where you can go. And a lot of the places that I interviewed at, simply put, it's not great for a spouse to be there. And so it's one of those things like, oh, I would love to be there, but my wife would be pretty miserable. So we got to kind of find a place that's manageable. And the practice that I joined in Silverton, Oregon, just kind of fit that bill. So we wanted to stay out west and still kind of like be in the mountains because we really loved everything that had to offer us. But the pay basically, frankly, in Oregon was like 30% more than anything I could get in Colorado. So it really felt kind of like there was a sunshine tax starting there where, it didn't matter where I worked or how much I worked, like did not pay well. It was like below national average, even with OB and scopes. And so I was like, we're going to have to go somewhere else. So I ended up finding that job in Silverton, and it was with a group practice. So it was a private group practice. I was actually paid like an employee, but, sort of treated more like an autonomous physician.
That's great. And, it speaks to my heart in terms of when you want to maintain full scope family medicine, going to a rural community, that's exactly what, I wanted to do scopes, and I wanted to make sure that I could do OB. I don't do deliveries, but to even just, see people for prenatal care. It was very, very difficult in California, even back in 2015, to find places where I could do that. And so, it speaks to my heart that what you were looking for was to keep being the doctor that you had trained to be, and to be able to do the things that you have the skills to do. So when you were looking, though, how did you find the Silverton group? Because for those people who are not necessarily thinking like I'm full bore DPC, but I'm interested in doing, a practice, I'm interested in joining a practice where I would be able to maintain my skills. How did you even find that group? Because it's not always, sometimes it's serendipitous, sometimes it's word of mouth, but how did you come to find that independent group? And are they still an independent group as of today?
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
The guy that owned the practice, he was a guy named Rodney Orr. He had gone to my residency program way back in the day. He was like, I want to say one of the first guys out. And he emailed the program director and said, hey, we're looking for another doctor. Are any of your upcoming graduates interested. And so our program director would always he would just blast those emails out to everybody. We were constantly getting emails about different job opportunities. And so I think I was like the only one who followed up on that one.
And there's a golden tip. If you're looking to grow your DPC, especially if you're already practicing and you want physicians to come in, whether you want a physician who does pediatrics and you don't, or you want, like in your case, Dr. Davenport, who's your partner, is internal medicine, where your family, if there's different specialties even that you want to come in, that is a great way to engage with residencies. I got an email that was shared with me from my old residency where a particular fee-for-service job was looking for a program director for a residency that they've already accepted residents to without a program director. They have an interim, like assistant program director, whatever. But it was like the emails that they get. Can you imagine if a program director read like, hey, like here's a fee-for-service job where, they're very pro DPC, they're very pro protecting the physician's autonomy. And they're like, but I also have this DPC offer that came in. So like, in the email, you can take a look at all these job offerings, but like this would be a great one to look into. And so I think that program directors are not blind. I get that a lot of programs are in, the Kaiser system, the fee-for-service system. But when it comes to program directors really fighting for their students and their residents, I really think that program directors in general have a really good sense about you would be a great fit because you love all the things. You love dermatology, you love whatever. And sending an email, just like how it affected your life, not to say that it was the best, because obviously you moved back to Michigan and you changed and went DPC, but just in terms of using that as an opportunity to get the word out there about your DPC practice, it's definitely something to consider. So going back to your journey in Silverton, you were introduced to the Silverton practice by somebody who had understood what it meant to be a full scope family physician from your residency. What happened in Silverton that made you come back to Michigan?
There was a lot that happened. So about a month into moving there, one of our family members came down with recurrence of kidney cancer, renal cell carcinoma. So it was some small metastases to the lung. And knowing what I know now, that's actually not the worst thing in the world. But at the time, I was like, oh my gosh, she has stage 4 renal cell cancer. This is insane. So that was super stressful because it was actually my wife's dad. And then they didn't want me to tell her because she was already really just in a tough spot. We had just had our first child and went through some things with like breastfeeding issues and weight loss. And she was super stressed out, no sleep. And then, so it was one of the most stressful times of my life. So we kind of make it through that. And then I'd say, 2 more things happened. One, there was kind of discontent within the group. And so there were some physicians that actually had decided to leave the group and start their own practice and split off. And they're still practicing. They're still independent. There's, I believe, 2 or 3 docs and a nurse practitioner. And then the old clinic, the guy that owned it, that had sort of recruited me, started practicing again. And then they've subsequently sold to Legacy, which is the hospital that had just bought the Silverton Hospital. So they're now sold off, to answer your question from earlier. Now, my wife and I ultimately decided to leave because she became pregnant with our second child. And we kind of looked at each other and we're like, every time our parents come out here to see us, it's just rough. They kind of like leave crying and wanting to see us more. It's not an easy flight. It's a 3-hour time difference. Colorado is a lot easier. 2 hours, for whatever reason, is a lot easier than 3. And all of our entire family lived in Michigan, and none of them were really able to move. All their jobs were pretty, set in stone in that state. So we were kind of like, look, we moved out here to be in the mountains, but we never go. Like, we have a kid now, and all we do is hang out in town and hang out with our friends. And we're like, we can do that in Michigan too. And we'll have all of our family. So I think it's time to go back. And that was just after a year and a half. Now, the story I want to tell, because it's one of the best DPC stories. I don't know. Have you had Rob Rossborough on?
Yes, indeed. December of 21.
So I don't know if he might have told this story, but I was so he was in that group that I worked with in Silverton, and he had already been thinking of leaving the group to do DPC. And the straw that broke the camel's back for him was me, because little did I know, but the practice manager did not tell the other doctors that they didn't tell them when I was coming. And they also didn't inform them they were putting my desk in their room, which was already this kind of small office with 4 desks in it for 4 providers. So I was the 5th provider in like a single office, and everything was just so crammed. And they gave me the window, and he was just like, that's it, like I'm done. And so he said that was literally the moment where he's like, I'm out of here. And so he started planning his practice and stuff. And then, Rob and I ended up becoming good friends. And he's one of the first people I called when I moved back to Michigan and was considering starting a DPC practice. And I was like, hey, should I do it now or should I wait a year or two, take a, kind of standard family job? And he's like, no, he's like, do it yesterday. It's the best thing you'll ever do. So anyways, just a great story. And he's got, I think, the biggest patient panel of any DPC doc I know.
Yeah. Hands down. I mean, it's like, I think he said over 1,000, if I'm remembering correctly.
Yeah. Now he's got a nurse practitioner helping him out now. But even before that, he was at like 850, 900.
Yeah.
I was like, well, how are you doing this?
Awesome guy, full of energy. Definitely take a listen to his episode. But it was the second to last episode of the first season of My DPC Story. So absolutely. But I don't think that he mentioned the office situation and the window specifically. I have to go back and listen to it myself, but that is awesome that we're connecting those dots. And now, I mean, you opened 2018, you opened Paradox DPC 2018, and then you've been off and running, and now Dr. Davenport's with you. But I think that's awesome. Let me just go back to your experience in Greeley, because in Silverton, because you didn't have the job, like you're saying, just take a family medicine job and then open your DPC. When you were in this fee-for-service job, something that you had written about, and I'm wondering if this came from your experience in Silverton or if this came from the experience in Greeley, was that you had mentioned in your bio on your website about how it was crushing to you when people would come to you with huge bills. Like that wasn't your intention to put people into bankruptcy for paying for their medical care. So I wanted to ask, where did that statement come from?
Just having people throughout that year and a half in Silverton where you'd order labs on somebody and they'd come back and be like, do you know what those labs cost me? And I'm like, no, I have no idea. Not a clue. And how was I supposed to know? Like, I don't know what insurance you have. I don't know what your deductible was.
It's so interesting because we're coming off the heels of Dr. James Gore talking about, as an emergency medicine physician who's now doing DPC at Halcyon Health in Irvine, California, how like the number one thing, and you and I know this because we lived this when we were on rotation in the ER, but it's like the number one thing you think about in the ER is, where's your face sheet? What insurance do you have? And it's like, we all know that life. But in primary care, I don't think I ever had the face sheet as the top page. Like in our clinic and fee-for-service, it was like the demographics, like who the patient is, what's their chief complaint type of thing. But it wasn't like a full face sheet with like, here's this and here's that. And in no class in medical school are we taught like, if they have a BUCA plan, that means they're coverage for blah, blah, because there is no transparency. I mean, we're working towards it. Great. But like, as you and I can say, like on your website, cholesterol, whatever is like $4 to check it. You can't do that. You can't know those things necessarily coming off from the curriculum that we get in medical school.
Can I tell you kind of a crazy story about this?
Please.
It just happened to me personally. I kind of like, I actually want to write an article about it. So my family and I have a health share plan.
Yeah.
And it's Liberty Health Share is what we have right now. And my daughter was having some episodes of vomiting and headache. She's 5. And she had like 4 episodes in a 6-month time period, and they were getting more frequent. And so I thought she deserves to get a head MRI, right? And as far as I knew, there were only 2 places I could get one of those, for a child, because you have to have a special like pediatric certificate for outpatient imaging of pediatrics. And my normal imaging center didn't have one. And I just kind of assumed the other ones didn't either. So I was going through Children's Hospital of Michigan, and a system called Beaumont, or what's now Corewell Health, but those are the two big like pediatric systems in the area. And they both can do sedation for MRI, right? Because one of the big issues is kids might move around and can't stay still for 20 minutes. All right. So both of them tell me that I can't write an order for my daughter. And we had talked to somebody who works at Beaumont, and she said that kind of just went into place like a year ago. And one person from Beaumont tried to tell me that it was against the Stark laws for me to do that. And I was like,
that's awesome.
You know what the Stark law is? Like, I don't have an investment in the hospital or the MRI machine or like what? So anyways, and they kind of treat you like you're a criminal when you do this, right? Like, I had the one lady from Children's call me. She was a doctor. I think she was a radiologist. And she said, our risk management team won't allow us to fulfill this order. You need to get another doctor to. So long story short, we agree to see peds neurology at Children's Hospital, which I thought, okay, that's fine. And who knows, maybe they'll tell us we don't even need the MRI and we can save the money. He agrees we need the MRI at the end of the appointment. I tell them we're cash pay, and they say, okay, the cash pay rate's $479. And I think, okay, for a hospital, for an MRI, that's actually pretty reasonable. And I'm fine with that. And if she needs sedation, they can give it to her. So we know we're going to get the study we need no matter what. Well, I then kind of tell the lady, I'm like, well, we are cash pay, but we do have this health share plan. And they had actually recently sent out an email that said, we have a new vendor and we now can bill directly for a lot of things. So I called Liberty Health Share. I told them what was happening and said, would you like to try to bill them directly? And they said, oh, definitely. They're part of this new network, this vendor. I think it was like PHCS or something. And then I called Children's and I give them the information and they're like, okay, great. Yeah, we can take that vendor. We can bill them directly. The cost is now going to be $5,000.
Amazing.
Up front, right? Because they have a policy that for anybody with my type of coverage, they want payment upfront and they want to bill you the maximum amount of your, what is essentially your deductible, but what the health shares call like your initial unshared amount or whatever. So they're going to bill me whatever my initial unshared amount is to the max. And so I try to fight this a little bit and I kind of take it up the chain and I end up talking to somebody's like manager. And the manager comes back and just says, I'm so sorry, but this is our policy and the price is going to be $5,500. So as I tried to fight it, and I had a bunch of people along the way say like, this is crazy. We should be able to take care of you. Like, well, you talk to my manager. The price goes up.
Oh my God. It's like an elevator. Next level up, next price up. Oh my.
It was insane. And so I'm like, okay, so you guys are just cool with your peds neurologist saying she needs an MRI, but me not getting one, because who has $5,500 to just shell out for an MRI? Nobody, I'm like, you see Medicaid patients all day long and don't charge them a dime. And you want me to make I don't know, $5,500 used to buy a car back in the 90s. So anyways, we ended up getting one through an outpatient imaging center called RMI that does have the pediatric certificate, but they couldn't do sedation. And luckily, my daughter stayed still through the whole thing. And it cost us $330. Long story, but I mean, it's crazy. Yeah, I was just going to say that kind of, that explains the whole idea of these, ninja bills and, people not knowing what they're going to have to pay for stuff. And makes me think of Ryan Newhoffel's article on Green Cross Green Shield, your grocery insurance.
Absolutely. And, when you talk about lack of transparency, fraud, when it just keeps going up, the more people you talk to, you said something there's a separate video on your website where you're talking to potential patients. You're like, hey, this is what we do. If this is a good fit for you, let me know. But one of the things you said in there is that you're somebody's guide in the jungle. And that is real, man. That is so real that like you and I have these conversations, I'm sure, on the daily where it's like, yes, you could pay for your lisinopril through your insurance or your MRI or your calcium score. However, the calcium score is not covered by the insurance, or the lisinopril you can actually get for a year for less than the same price that you're paying through your PBM or whatever. But it's like, I don't know about you, but it's like, I was never able to say these things had I not been able to log into my, wholesale website and be like, the current cost of your lisinopril is like pennies on the dollar compared to what you're paying now? Or would you like to see the menu of cash pay pricing at our local radiology center? I have that saved on my phone as a graphic so that I can easily, people, like I picked up free, cubicle panels in Sacramento one day. And the dude was, talking, oh, you're a doctor, blah, blah. I'm like, oh, you need an MRI for your knee? Well, the price is this if you go to Modesto and do this. And he's like, how did you know that? I'm like, because I work in cash, I work in transparency. And so when it comes to people who have understood Paradox, what are some of the things that you hear? Because there's a montage for those people who've not been to Paradox DPC's website. There's a montage that you guys have of your patients. But one of the things they talk in there about is, that health insurance. There's one patient in particular who said, I'm really understanding that health insurance is not health care. So when you have patients coming into the practice, like what are some of the things that you're hearing from them that Paradox DPC is helping with or saving them from because you guys exist?
Yeah. So back to the health insurance is not a healthcare comment. It's kind of a cliche sort of in a way, but it's super true in that, especially for that particular patient, he had health insurance and then his family member went through a whole bunch of stuff where she needed a ton of health care and they were just getting bills constantly. And so what he realized was this insurance doesn't really buy me anything. It might kind of protect my family members from dying, but if they actually need help when they're not well, I'm going to have to pay for all that out of pocket. So I have to essentially pay in addition for my health care, which is the actual care that you're receiving. And so that's that comment, and I think a lot of people come to DPC for that reason. I have some other friends that, told me stories about going to the ER and, nothing happened in the ER. And then they were admitted and they got a bill for the ER visit for $3,000. And they're like, called up the hospital. They're like, you did nothing. What's the $3,000 for? And so they get fed up with it and they're like, I want a different doc. And frankly, that's kind of like the big reason why I started DPC, because I was having these conversations with people and I thought these people aren't just complaining about their healthcare. They're looking for an alternative option. So I think what Paradox Health can help a lot of people with, it's just kind of the classic, three legs of the stool DPC thing, which is, it's the only solution that can simultaneously solve the problems of quality, access, and cost. So I think that we do that pretty well. I always kind of, when I started this, I didn't want to have just a kind of quick visit clinic, for a low monthly membership fee. I wanted to provide the highest possible level of care for still an affordable price. And I still think it's super doable.
I love it. I want to ask you about your founding days at Paradox Health, but I want to ask one thing, as I'm mentioning these videos, one of the things that I loved at the solo video that you did at the end of it, you said, you want to know more, go to my website, or simply pick up the phone and dial this number. So, in terms of engaging patients who are potential patients who've never met you before, what was the reason that you said, just pick up the phone and call versus go through the website? What was the intention there?
Well, when I made that video, that would have forwarded to me, but I definitely, you're much more able to explain DPC over the phone than you are via website. I think that's one of the biggest problems that we have is explaining what is direct primary care. I think it's a simple idea, but it's so different. People have a hard time understanding that it's real. And they always have additional questions or they think that there's some kind of a catch or a hook. So that's why I think phone conversation is always easier. And it's not like we're getting 100 phone calls a day. So it's pretty easy to field those calls.
Love it. And going back now to the opening of Paradox Health. So when you had talked to Rob and he was like, dude, just open from day one. Don't waste your time doing other things. Just put all eggs in the basket and open your DPC. How did you go from Silverton to opening? Did you move to Michigan first, take some time off and then open? Or were you like working the DPC already from Silverton?
No, it was the former. So I just basically moved here. We had some savings. We had sold our house and we moved right around Christmas time. And so I was like, I'm not in a rush to get a job. I'm just going to enjoy my family and hang out. And it was really nice. It was a great time. But then quickly I was like, I need to start working again. So I started doing some locum stuff at urgent cares and very quickly realized I didn't want to keep doing that because that's horrible. And I had called Rob, and then I also met with Paul Thomas down in Detroit, who started Plum Health, and we met for lunch. And after that conversation, I was more so, kind of convinced that I should do it and had a much better understanding of what it took to start up. That's always kind of the question that people have is, well, how do I do this? And it's really not that hard.
So going from this place of, experience and being a successful DPC entrepreneur, I want to toss in there a statement that you had made also in your bio that, you were talking about giving care directly versus indirectly. You mentioned how in med school you really wanted to do this direct care for people, but it took the right prodding and the right people to tell me that you weren't crazy. So when you talk about, meeting with Paul Thomas, meeting with Rob, and, finally coming to this place of like, okay, yeah, I can do this. What was it that, in addition to just the sequence of events, what was it that made you say like, today is the day that I am opening?
I didn't really have a grand opening. I was more so just having conversations with people and letting them know what I was doing. And I have a pretty good network here in Michigan. So it really my first day of opening was probably just the day that I got my tax ID back from the federal government. That was about it, and then I opened up my business bank account and I was like, okay, I'm open. So I didn't really do this big announcement. I never had the Chamber of Commerce come do some grand opening thing. I mean, I should have, but I didn't. And I started seeing people at home before I had an office. So I was doing some home visits and still doing a ton of work at urgent care. And then I eventually started doing some telemed stuff. But that was it was just like, as soon as I could open, I opened,
Love it. And I hope that gives people encouragement in terms of when you're opening, like Dr. Hellman's not mentioning, I get it. Like I am totally envious of Dr. Brian Blank's Ember Modern Medicine in Greenville. It's absolutely ridiculously beautiful. Listen to his episode to hear more about that. But I will say that we've talked about this on the podcast so many times. Like if you're wanting to open, let that drive you rather than, I can't open until I have this, The people want you. The people want a different way of doing healthcare. The people I'm super envious of amazing buildings and clinics. However, you do not need that to open. And I think that, by hearing your words as to it wasn't a grand opening, similar in my neck of the woods, I didn't have a ribbon cutting or anything like that, other than buying some ribbon off of Amazon and some big ass scissors and just taking my kids to the levee and having my tripod, take a picture of me and my husband, my kids and my dog. But it means so much to you as the doctor opening and doing DPC. That's the thing that matters. That's the things that your stories are going to be around. That's the thing that you're going to tell your kids and your grandkids about. So when we talk there about you opening, and I love that you just did it. You did telemedicine visits first. At what point did you decide to open a physical location?
I'd always wanted one. It was just kind of a matter of finding a spot that I could afford. So I rented a room from a friend who's a chiropractor. That was my first office, and I was there for 2 years. And it was super cheap, really low overhead and great visibility. It was in a really high-end strip mall, so plenty of parking. And I just had one room and I had everything in that one room. So, and a lot of people do that. I'm definitely not the only one who does that. So, and for me, I'm not a huge risk taker. I already had a ton of student loans. I didn't want to take out a big loan and, rent some massive building and hire a bunch of staff. And, that's just not really my style. So just started out kind of slow. And I think it also really helps to work the kinks out. If you just start kind of low profile and you see some people and, you're printing scripts and you're kind of working through, okay, what are the hiccups? How do I do this? What are the nuts and bolts of how I'm actually going to do this? Those first 20, 50 patients are kind of like your beta testers.
Definitely. And when you decided to open and you finally opened your doors, you're doing medicine, just about a space initially, and then moving into this one room clinic in the chiropractor's office, how did patients find you? Did you, have all your family tell everybody they knew, or did you do an open house even with the space you had? How did you get patients in?
I never did an open house. I still think I might at some point. Maybe for my 10-year anniversary, I'll do a ribbon cutting. So most of it was just word of mouth at first, just telling friends and family, hey, spread the word and that kind of thing. Had some stock cards made up, went around to some businesses, had some really good conversations with businesses at first. And then the thing that really helped was I joined a BNI group. For those that don't know, Business Networking International, it's kind of this cliche, taboo group that people join that's really kind of corny. You get up and you do a presentation for 30 seconds at the beginning of every meeting. It's once a week, but it was great. And I met some awesome people. So a lot of it, I think it just depends upon the group that you get in with. But I'm still friends with a ton of these people, even though I'm not doing it anymore. And at one point, 10% of my patients were a direct result from that BNI group.
Wow.
Which is huge. You think that's thousands of dollars of income just from that one decision. And, the group costs like $500-600 a year to be a part of. And then I was doing the Chamber of Commerce stuff, going to those events, going around talking to people, got a business out of that. So I think, and you don't see a direct result from that kind of stuff right away. It's the long game. It's conversations you have with people. And then a year later, they call you and say, hey, I saw you at this event a year ago, thought about calling you, but I never did, but now I am.
Yep.
And it also just helps to keep you busy, because early days of DPC are pretty dejecting. You're just sitting around doing a whole lot of nothing, and you don't have a lot of patient appointments. You're not doing podcast recordings and you just need something to fill your time with. And it is productive, even if you're not getting patients right away. You got to kind of look at it as like planting the seeds, and eventually it will pay off.
I loved, because I was doing podcast recording while I was waiting for patients to join the practice. But
you're smart.
But what I will say is that just even, I will throw a big shout out to Dr. Jalen Pritchard, who's also been on the podcast. She's in Spokane, Washington at Thread Health. But she is a perfect example of how, when you have the time, like similar how we talked about, like you dove deep into lipidology, she delved deep into how do I do DPC? What are all the questions I have DPC? And I love that, because there's so many resources that we have now, especially compared to when you opened, that the resources are endless in terms of opinions on how to open, how do you do your overhead, how do you do your P&L, who do you hire for a coach, do you hire a coach, all of these things. Like there's all of these resources that are in existence because there's more and more of us out there who have stories and have stories that have been shared. So I think that, as you're sitting there waiting for those patients, planning for those patients to come, it's definitely a time that I miss sometimes, because I'm like, man, I wish I had more hours in the day to do XYZ, putting specialists into my EMR so it's ready to be used for referrals and all these little bits there. But it's definitely, it's something important to hear, because if you're expecting like, Dr. Kissy Blackwell, I'm going to have 278 patients on day one, it's like, awesome, go for it. If that's you, you do you. But I will say, for those people who might not be in that same boat, it's okay. It's okay. Like, we are still alive. We are still open. And we are having patients who, like you said, like we planted the seeds and then they come later. I saw one of those patients yesterday. She was talking about how she did not realize how important it is in rural America, in our case, to have access to a physician when you need it. And unfortunately, something had happened with this person's spouse where there was, a need to contact the doctor after hospitalization, and there was nobody. And so I love that as patients find us, it speaks a lot to the patients who understand what we're doing, who want us, and then they become our patients. Those are the people that they might be skeptical. Like, I think Dr. Emily Scott said one of her first patients was like, am I on candid camera? Like, is this real? And but it's like, yes, this is real. And yes, we are here for you as long as you have openings in your practice. So I say that because it is, like you said, if people are thinking about like, oh, these first days, they might be scary. It's okay. I just wanted to put a word of reassurance there. Yeah. Now, when it came to, you said that in 2018, like you were open for 2 years in this chiropractor's office. What happened after start of the pandemic? So March of 2020 hits. how did your practice fare in terms of, did your practice grow and that allowed you the income to then go into a space, or what did Paradox Health experience during the pandemic?
Explosion of growth. I'm trying to think about how many patients I had pre-pandemic and then post-pandemic. What I can say is I was doing some telemedicine still pre-pandemic. And then I was actually doing it. They had upped the rates that they were paying. So I kept doing it at the beginning of the pandemic, like a ton of it. And I mean, it was great. I mean, I made a lot of extra money that year from doing that. But then, I think I probably stopped doing that stuff towards the end of 2020 because I had so many new patients that had signed up. And the reason was we were treating people for COVID and nobody was. So, I mean, we even had doctors coming to us asking to be treated. And, it was just kind of the same line at every other clinic was, stay at home, good luck. If you can't breathe, go to the hospital. And so we were seeing people, we were closed for the first maybe 2 months of it. I was still seeing some people in person, had a guy slice his knee open with an axe on Easter. So I came in and sewed him up, but I wasn't doing physicals for the first 2 months, 3 months when everybody was kind of really unsure as to what the heck COVID was. But then once we had a better understanding of it, we opened back up and that was it. I mean, we just, like I said, we just exploded with members. I had to close to new patients for a little while because I was so busy treating people for COVID and then also seeing my own patients. So February of 2020, I was at 351 patients. And then this would be February of 2022, I was at 701 patients. So that's basically doubled my patients in 2 years.
That's some Rob Rossborough action right there, man. That's crazy. That's crazy. Yeah. So let me ask you there, because, the word was getting out, and especially because you were treating COVID and people were finding you. And then I'm guessing learning more about the practice and then deciding I can't not have access to this amazing doctor, whether there's a pandemic going or not. But at what point did Dr. Davenport join your practice? Was it during that time to help you, get all those patients onboarded?
I met Dr. Davenport towards the end of summer, fall of 21. I remember because it was I play in this Friday night hockey skate. And it was the day that I met her was the first skate of the fall. So it was late September, early October of 21. And she ended up joining, I want to say it was March of 22. That was kind of her timeline for when she could come. Yeah. And then how I met her was she had been interested in DPC for a while, and still is a part-time program director for an internal medicine residency in Pontiac, the McLaren Pontiac internal program. And she just been kind of looking to get out of it. And so she met with actually Paul Thomas, or called him and had a conversation with him. And then Paul directed her to me and said, hey, if you live, she happened to live a mile from me. He said, hey, if you live up there, you should just give, Phil Hellman a call and talk to him. So we met for coffee and, hit it off.
That's awesome. I will drop here. I sent a message before the podcast, but I will drop this here the first time. And I don't know if she remembers. So when she hears this, she's going to probably die laughing. But I was quickly going down to, I think, set up the My DPC Story banner or something at the DPC Summit in Kansas City. And I was in a Back to the Future sweatshirt and socks and sandals. And she's in her tank top going to the POCUS workshop. And I was, hey, what's your name? And so she was, I'm Lyndsi Davenport. I was awesome. It wasn't a big conversation. It literally was that. This is what happens when I meet people. The first image I have of you is at the 301 session. And the first image I have of Lyndsi Davenport is, I don't look like a doctor, but I really am. It's good times. But so when you guys connected, and I know that she was wanting to do DPC, as you mentioned, but how did the conversations go to bring her into Paradox Health?
Well, it wasn't that difficult. She was pretty much said, look, I want to do DPC, can I join your practice, essentially? And so it was really just a matter of kind of ironing out the contract and that sort of thing. And it was very easy because she said, I don't want to be a partner. I don't know anything about business. I just want to see patients. And I said, perfect, because I'm not, struggling with the business aspect of things. We've got tons of patients coming in. And I was at that point where, if you've been open for 5 years and you're a male only practice, you get a ton of patients who say, hey, I'd really like my wife to join, but she really wants a female. And hey, have you ever considered hiring a female? Yes, I have. It's not as easy as you think. So yeah, it was perfect. And it would be nice if she could see kids, but I'll take it.
Awesome.
So yeah, it worked out really well.
And when she immediately came on, as she did you just have her come on as a 1099 then? So she was able to.
Yeah. I mean, she probably doesn't care me saying, but she still gets paid as a 1099.
Well, that's how Dr. James Goora and Dr. Emily Scott do it at Halcyon Health. And they spoke to that on the podcast because there's different ways of bringing people on. But I think that from how do we get you, your feet wet and you going to see patients and you doing, what you need to do in DPC as soon as possible. I think that's a very reasonable and easy way to do it, relatively speaking. So when she came on, how did you manage your patient panel versus her patient panel? Because on your website, you have the option, are you looking to see Dr. Hellman or are you looking to see Dr. Davenport? And then I'm assuming you have different sign-on links on the back end from that part of your webpage? Yeah,
well, not different sign-on links. It's the same link, but you just click a drop-down box and they can pick which doctor they want. So at first, I was essentially, when she came on, I closed to new patients. And then so on the website, it said join Dr. Hellman's waitlist or join Dr. Davenport's practice. So I was trying to funnel people towards her, mostly just because I was so busy, but also because I wanted to fill her up. We also had a wait list from COVID. And so we called on that wait list. It was about 60 people. And I don't know, maybe a third of them, ended up following through and signing up. So that worked well for a little while. But then, there is attrition in DPC. You have people that drop out for whatever reason. I think the number one reason here is people move to Florida. It's, as funny as that sounds, is pretty true. A lot of people moving to Florida. So you do have to replace those patients. And I finally got to a point maybe 6 months back where I just said, you know what, I need to open back up, because I also started finding out about people who had chosen not to join our practice because they really wanted me as their doctor. They wanted a male doctor. And they're like, well, he's not available, so I got to find somebody else. And, a lot of these people they'd be great patients. And so I opened back up, and now we kind of have it as, you pick your doctor. I think the long-term benefit of that is that you want patients to be with who they want to be with, not who you want them to be with. And that, in the long term, that's always going to work out for the best.
But I think it's awesome that that the patients are asking for options and you have provided options. So I think that's great.
Sorry, the other thing I didn't mention was we sent out an email and basically gave all of my patients the option to switch over to her. So especially a lot of the female patients have chosen to do that throughout time.
Gotcha. And in terms of just looking back on that experience, thankfully, Dr. Davenport was there. She was wanting to do this. She was like, I want to get started as soon as possible. But for people who are not necessarily as lucky or as fortunate, what advice would you have to people who are looking to hire physicians into their practice in the future?
Well, as far as where to look, as far as I know, I mean, residency programs are a great option. Like we kind of talked about before, emailing program directors that are local, or even ones that aren't. If you know people that are, maybe from your neck of the woods, but they're doing residency elsewhere in the country, as well as just, hiring a recruiting firm or posting on Indeed. I mean, those are all kind of the standard ways of doing it. I'm yet to do that, although I might be there at some point. And so I'll probably have to learn more about that process. But the biggest thing I'd say, and this is more so coming from a lot of other people I know who own businesses, is it has to be a good culture fit. And I think now more than ever in medicine, with it being so politicized and divisive post-COVID, you really want to make sure that this is somebody that you can work with long-term. So instead of just looking at, kind of what do they look like on paper, is this somebody you want to spend time with and that you can work with easily?
Absolutely. And I think that is such a powerful statement. It might be a general statement, but it is very powerful because culture speaks to so many things. How do you cover call? How do you take care of each other's patients? How do you, the culture of the office is a uniform culture. Like some people might argue that, but for me, it's like, that's the clinic where there's a lot of time with patients, or that's the clinic where it's relationship-based medicine, not transactional-based medicine, like you put in your video. But I think that, the clinic being uniform really helps also build the word of mouth for the culture that you're bringing to the community. So I think that's really important. Yeah.
And I can say that I know at least a handful of fee-for-service docs that have left their practices because they had no choice over the staff that was hired, and the staff just destroyed the clinic.
Absolutely. I think we can all think of, people who we've worked with in our training up until now that it's just like, oh my gosh, like I am so glad to be working with another person rather than that person. Oh my gosh. Yeah. Like for me, it was somebody, one of my MAs at my fee for service. She's like, I can set the stuff up for you. I'm like, well, I was not used to having anyone set up my procedures for me. So it's like, things like that, where if you're in one culture, there is a way to think about, could it be done differently? And then those are the types of questions also to ask, if there's a DPC practice that you're looking to join or you're interested in joining, ask about like, how do you guys do specific things? Like, how do you guys cover each other's call? Like, what happens if in this situation or that situation? Those are ways to learn about the culture if you're looking to join. For you guys have Mia. Is Mia your only staff member in addition to the two of you?
It's Mia, and it's me when she's on vacation.
Love it. Love it. So let me ask you, how did you find Mia and what role does she serve at Paradox Health?
So Mia is my good friend's daughter. And basically, I was kind of having a nervous breakdown during COVID at one point because it wasn't so much the volume of work or the time, but just the amount of phone calls I had to field every day was just driving me insane. And so I was actually at the gym on a Sunday, and Mia had just finished a phlebotomy course, maybe like 2 months before. And she had actually asked me, like, are you looking for anybody, to work at the clinic? And I was like, no, not really. But that was before I got really busy. And so it was Sunday, we're at the gym, her dad's there, her whole family's there. And I was like, I just kind of had this epiphany of like, if she comes to work with me tomorrow, I'm going to survive. And so I was like, can you come to work with me tomorrow? And she didn't have a job at the time, or she did, but it was, I think she was like waitressing at night or something. And she was like, oh my gosh, yeah, I would love to. So
love that.
And from there, I kind of just looked at it as like a temporary thing. But then we got so busy and I got so many new patients. I was like, if you want to keep working here, I still need you, And so I've been really fortunate, really kind of blessed that I haven't had to do a whole lot of interviewing, and the people have just kind of fallen in my lap. I actually did interview one MA for the position. She had lost her job because she wasn't getting the COVID shot, and she was really experienced. She was like 20, 30 year MA, really good. I made her draw my blood on the spot, and she was like really nervous, but she did it perfect. And she ended up saying no. She's like, no, I couldn't pay her enough, was kind of the long story short. So anyways, hired Mia, and that's where we're at. And she does everything. She answers the phone. She draws blood. She does vitals. She gives shots.
Very cool. And in terms of with you having Dr. Davenport, with you having Mia, and you having, not the crazy of the pandemic happening right now, like it was back in 2020, I want to ask you, what has DPC allowed you to do differently? Like clearly talked about lipidology, but what has DPC allowed you to do differently, whether it be your professional practice or your personal life?
Everything. Do you want to have a whole nother podcast just on that? I like Josh Umber's and statements. I don't know if you're familiar with this, but, I can see fewer patients and spend more time with them and spend more time with my family and take more vacation and make more money, and be happier, all of the things, I think one of the coolest things about being a DPC doc is that you get to block off your schedule. If you have something going on, you just say, you know what, I have something I need to do. That time is blocked off. I can see patients, for the rest of the day. And we don't have so many patients that that's actually a problem. You're not seeing 20 people a day. And so you're not saying no to 10 people. You're saying no to like 2 people, 3 people. And you've got plenty of other openings the second half of the day and the day after and the day after. And so I think, I read a book recently called The Ruthless Elimination of Hurry. And I think one of the coolest things that DPC allows you to do is to not be hurried. And hurry really is kind of, to me, like the root cause of all evil. Whenever we're hurried, we're not spending enough time with our patients. Whenever we're hurried, we're short with our spouse. Whenever we're hurried, we're stressed out. And so if you can eliminate that, it really just makes a world of difference. And I think DPC is the only tool that allows docs to do that.
I love that. So let me ask you in closing, when you think about the future, is anything coming down the pipeline for Paradox Health?
No, actually, I didn't mention this to you before. I looked at buying a building and then I found out what the property taxes were. And I was like, well, I guess I'm never doing that. So that was going to be a big change. I was really thinking about that. And I think that might actually be part of like a DPC education that would be useful for people, because it's the world of commercial real estate is so different than residential. So no, for the foreseeable future, we're just going to be probably in this office. We could probably take on another doc, but we kind of we would like Dr. Davenport to be a little bit more full before we kind of pull that lever, but I think that that's probably the next step would be to find a family practice doc, somebody who can see kids and go from there.
For sure. And did you want to mention the transition from lab to lab?
Oh, yeah, sure. So one other thing that's not like super interesting, but really important is we're switching from Quest to LabCorp. Quest has been really great. And we're pretty happy with their labs and what they offer, but they increase their prices every year. So they have like a 7%, I want to say, inflation rate that they just add on to your prices every single year. And so it's gotten to the point where some of the labs are just kind of ridiculous. And my standard panel I order on people now is close to like $180. And I'd really like to lower the cost of that. So, we're going to do kind of a legacy price increase. So some people that came in early to the clinic are in like a lower price tier than what our current prices are. So we're probably going to try and catch those people up to current pricing. But then we're also introducing the switch from Quest to LabCorp, which will, in the end, if you get your blood drawn with us just once a year, will end up saving you money in the long run. So, even though your monthly membership fee might go up slightly, if you get your labs drawn with us once a year, you're still saving money out of the whole deal. So I really like the idea of just looking wherever you can to save money on overhead and save money on costs for patients. I think a lot of people get a little bit too lazy and complacent about their practice and stop looking for savings for patients. And we should just always kind of be looking for that, kind of similar to how, Costco hasn't raised the price of their hot dog. They started their own hot dog factories.
I love that. That's the understandable, because I can totally relate. Like, we've been, Price Club members since 1984. So amen. Like, everyone can understand that. Thank you so much, Dr. Hellman, for joining us today.
Yeah, thanks for having me. It's been a lot of fun.
Thank you for joining us for another episode of My DPC Story, highlighting the physician experience in the world of direct primary care. I hope you found today's conversation insightful and inspiring. If you want to dive deeper into the direct primary care movement, consider joining our My DPC Story Patreon community. Here, you'll have access to exclusive content, including more interview topics and much more. Don't forget to subscribe to My DPC Story on your podcast feed and follow us on social media as well. If you're able, I'd greatly appreciate if you could leave us a review. It helps others to find the podcast. Until next time, stay informed, stay healthy, and keep advocating for DPC. Read more about DPC news on the daily at dpcnews.com. Until next week, this is Marielle Concepcion.